Hello everyone. Good afternoon everyone and welcome to the today's webinar. Thank you for taking time to join us. I am Dr. Nagraj S. Maka from IIP Digital Media team. I'll be the host for today's webinar on stroke hand rehab on 9th November 2025 by resource person Dr. Anup Jarnia, organized by IIP Women's Cell Mohali, Punjab. The Indian Association of Physiotherapists is the oldest and largest association representing the physiotherapists in India since 1955. The IIP Digital Media team consists of a group of physios who handle the Zoom platform, webinar live streaming, and IIP profiles on social media platforms like Facebook, Instagram, Twitter, LinkedIn, and YouTube. Follow the IIP profiles on this social media to receive the notifications for our events such as webinars, workshops, CMEs, conferences, and health camps, blood donation drive, and to know about the recent updates on the physiotherapy. Subscribe to the IIP YouTube channel for notifications of our live webinars. In playlist section of this channel, the webinars are segregated into the various folders like topics like orthopedics, neurology, sports, fitness, pediatrics, cardiopulmonary, women's health, research, cancer rehab, and so many so far. So for easy access, the social media links will be shared in this chat shortly. So without much wasting time, with best wishes, I would like to hand over today's webinar session to Dr. Nishtha Dogra. Over to you, ma'am. Ma'am, Nishtha Dogra is there, right? Yeah. Ma'am, please unmute yourself. Ma'am, there will be a mic session. I have given you as a panelist role. You can just join that. Ma'am, can you raise your hand? Yeah, I have given you option, ma'am. Can you please check now? Yeah. Can you unmute yourself?
Am I audible now?
Yes, ma'am. Yes, ma'am. You're audible. Please go ahead, ma'am.
Good afternoon, everyone. As Dr. Kang is currently occupied elsewhere, so on her behalf, I will be moderating today's webinar. I'm also very lucky to have an opportunity to introduce Dr. Anu for this innovative and insightful session. It's my pleasure to introduce our speaker for this session, Dr. Anu, a highly experienced neurophysiotherapist and co-founder of AH Stroke and Physiotherapy Clinic Mohali. Dr. Anu completed her master's in neurology from Jamia Hamdard University, New Delhi, and has over 18 years of clinical experience in neurorehabilitation. She has worked with the reputed institutions like Max Hospital, Saket, and conducted numerous workshops and training programs on neuroplasty based rehabilitation for stroke and cerebral palsy. Her expertise lies in integrating neuroplasty principles, manual therapy, and functional task training for promoting faster and more meaningful recovery in the neurological patient. Today, she will be sharing her insights on the restore hand function after stroke. Now, I would like to hand over to Dr. Anu, who will continue the webinar and share her extensive knowledge on stroke hand rehabilitation.
Thank you, Dr. Nishtha. Thank you so much for the introduction. And I welcome everyone on this platform today. I would again like to thank IAP India, IAP Women's Cell, and IAP Women's Cell Mohali branch for giving me this opportunity to spread knowledge about stroke hand rehabilitation. And I would like to share my screen, Dr. Nagraj. Give me a minute, then we will talk this,
Sure, ma'am.
take this topic further. Yeah, one second. Is my screen visible to everyone?
Yes, ma'am, you can go ahead.
Okay, great. So, I'm sure in today's audience we have students, professionals, clinicians, and physios from all across India, because we have got a very good response from various states. And I hope that you have some positive and good takeaways from today's session. So, please pay attention, listen carefully, and if you have any questions, keep them for the end so that we can go uninterrupted and take the queries towards the end of the session. So, the topic for today is stroke hand rehabilitation for physiotherapists. And my aim is to make sure that by end of this presentation, everyone is able to understand the evidence-based strategies we use for stroke hand rehabilitation, especially how we move from a flaccid stage towards a functional recovery stage, right? So understanding the stages of hand recovery in the post stroke stages, understanding the foundational principles of neuroplasticity, because neuroplasticity is the foundation which we're going to talk about today in the rehab approach. We will also learn about how evidence-based positioning techniques and tools promote recovery, how we can explore the sensory priming strategies to enhance motor learning outcomes, and of course, understanding more about motor control and motor relearning approaches for the hand function. We will try and discuss a little bit about how a lot of assistive devices and functional electrical stimulation and robotic devices and new hand applications are coming up, which help not only in the clinics but also in the home care setups for people to recover from the different stages of home rehabilitation, right? And also we'll understand how rehab has to be stage specific. It should not be random. Like as a physio, we should understand how a patient is going to move from day one till how the progression is going to happen. So we will understand about stages, and will at the end of the presentation you will be able to appreciate the importance of integrated interdisciplinary approach to the care of a stroke patient. Now, when we talk about stroke, right, let us first understand how stroke basically happens. There are two kinds mostly we encounter in clinical scenarios: ischemic strokes, hemorrhagic strokes, right? And ischemic strokes are more common, of course. So when the stroke happens, what happens clinically? The presentation is mostly of hemiparesis, right? If the brain's right side is affected, the patient presents with a left hemiplegia. If the brain's left side is affected, the patient represents with the opposite side of hemiparesis. And upper limb, I'm talking about upper limb or hand today because it is more functional in terms of all our activities of daily living are more or less correlated with whether we are able to manipulate objects with our hand or not, right? So hand recovery is crucial to understand. And yes, patients uh, possibility of going back to work depends majorly on how they're able to handle tasks in the ADL from their hand, right? Now, when we talk about the damage or the pathology which happens in the stroke is, during the stroke, the blood supply is interrupted, either due to ischemia or due to hemorrhage. So what happens? The corticospinal pathways, right? They are damaged. The corticospinal pathways are not really now sending signals from the brain to the muscles or the peripheries. And similarly, the sensory signals are not able to really go back to the brain and, create that kind of neural map and neural feedback to ensure that a proper functional task is achieved, right? Leading to the hemiparesis and various other presentations. Now, when we talk about how the recovery starts, right? Brainstorm has given a very clear picture of stages, and I'll be taking this as a framework to discuss today's webinar discussion. Brainstorm approach provides us with a very, very recognized framework for the understanding of the progression of motor recovery after a stroke. right? Now, when the patient starts in the initial stage, it could be like few hours to few days. Stage 1 is mostly flaccidity, right? Immediately after the post stroke, what happens? There is no control of the movement, there's hardly any tone in the muscle, so it's a stage of hypotonia, absence of reflexes, and complete lack of voluntary movement, right? Now, during this stage, what we are going to do, we'll discuss in the next slides, but let us in this slide understand about the stages specifically. When we move to the second stage, what is happening? The tone is gradually coming back, but the patient is yet to come into a voluntary control, right? So the patient is presenting with emergence of spasticity, right? The spasticity starts to be visible. Now, as a physio, our role is to enhance the motor output at that time, utilize the patient's ability to bring maximum from this stage, right? And as the patient will move to the next stage, the idea is to ensure that because the spasticity is increasing, synergy pattern is visible. And in upper limb, mostly we see the flexor synergy pattern where the shoulder is in flexion, adduction, elbow is in flexion, wrist is in flexion, fingers, thumb, everything is in adduction and flexion pattern, right? So the approach has to make sure that this synergy is not leading to any contractures. We're able to achieve the range of motion properly, and we are the tone, whatever is available, we are converting that towards the functional activities. We are using this tone to uh, break down into things which which utilize the tone coming in the patient, but not uh, m- kind of minimizing the impact of excessive tone, excessive spasticity the patient is presenting. And when we repeat in activities, the patient comes out to this fourth stage where the spasticity starts to decline. At that stage, some voluntary control is there. Now the synergy is kind of breaking down, and we are able to do more coordinated movements, more out of synergy movements. Out of synergy movement would be if there is flexion at the shoulder, maybe the patient is able to do extension at the elbow, so pushing the objects out activities, or do able to achieve the wrist extension with the elbow extension. So again, that is a starting of coming into the coordinated movements, out of the synergy movements. Then the patient moves to the complex movement stage where further the reduction in spasticity happens and better range of motion is there. Better controlled movements are there, right? And then patient moves to sixth stage where spasticity is minimal, almost not a normal control is there, but still patient is in the recovery stage. Why? Because strength is something we need to still work on. And then patient moves on to the normal function where almost every function we have achieved, complex movements are doable by the patient, coordination, dexterity is happening. The idea behind discussing brainstorm approach is to identify and understand that recovery goes through a process, and these stages tell us about some predictable stages, and understanding these stages will guide us with appropriate interventions and setting realistic expectations for recovery. So as a clinician, you have an idea how patients flow will be. As a clinician, you can tell patients relatives about how prognosis is going to be. And when I talk about prognosis, let me share a very interesting fact with all of you here. Research studies have said that if a patient shows, uh, in the initial 3 months, some action in the hand, the patient is likely to, like in the initial 24 days, if there is some grasp function is there, at the 3 months time, patient will be able to achieve hand function in a functional way. But if till the 3 months there is hardly any hand function, it's unlikely that patient's full motor control will be available at the hand. So time is crucial. And why I'm talking about this is because time is one of the factors in the neuroplasticity principles which gives you the importance of why we need to start early. in the stroke rehab phases. So when we understand and talk about hand rehabilitation, let us also understand that what is our approach on which we are basing our rehabilitation. That is neuroplasticity. And what is neuroplasticity? It's nothing but brain's ability to reorganize itself. So once a insult to the brain has happened due to stroke, what happens? Brain tries to reorganize itself. Brain tries to adapt to that damage which has happened by forming new neural connections. And this is the beauty of human mind, human brain, that it can adapt, reorganize, readjust, and figure out ways to return back to the function. This ability is neuroplasticity. And there are some principles by which we can either increase it or we can ignore those principles and reduce or decrease the patient's potential for the recovery. So that's why understanding the basics of neuroplasticity is crucial. It's the cornerstone of stroke recovery, I say. Right? Because brain's ability to facilitate the reacquisition of motor skills will be dependent on few basic things. Like, basically there are 10 laws which are mentioned, but here, because the presentation is not about neuroplasticity itself, I'll be focusing on few main ones. So when we are talking about the hand rehabilitation, focus on the intensity of your exercises. High intensity training will deliver better results. So high intensity training with lots of repetitions per session will promote the cortical reorganization and motor recovery, right? Next principle is neuroplasticity is repetition. So if you do something once, if you make the patient maybe, hold the glass or hold the spoon, that function only once, or maybe you're giving them a repetition of exercise for 10 repetitions, 15 repetitions, you tell me, is the patient likely to succeed with 10 repetitions or maybe 100 repetitions? Consistent practice strengthens neural pathways. How? If I have to talk about the structural reorganization now, what happens when we post stroke, when the patient is trying to learn a new task, once you practice it, a signal is going, some changes happening, chemical changes happening in the brain. You repeat it, it's been consolidated. Repeat it again. Continuous repetitions lead to that synaptic change happening in the brain, which is basically like creating a new pathway. Imagine you're going on a road, okay, and that road is blocked. Now, the chances of you reaching to that destination beyond that blocked road would be high if multiple times somebody is coming and trying to, hit there and checking, okay, there's no route beyond this blockage, and then trying to figure out some collateral route, right? But if imagine there is nobody coming again to figure out where to go, it's unlikely that anybody will be able to reach to the destination. This is the concept. If you have to make your patients understand how this principle works, when you're taking the sessions in the clinic and you're asking them to do multiple repetitions, emphasizing and making them understand the importance of repetition, also repeating the exercises at home, patients' compliance will always be better if they understand the concept of neuroplasticity better. So you can use this example to make them realize the importance of this repetition specifically, right? And the next thing is specificity. Specificity means the task specific training ensures brain's reorganization is relevant to the desired motor skill. I can ask the patient to, okay, make a fist open, or move your wrist up and down, and patient might gain the function. But if I'm making this same action task specific, how? By maybe giving maybe giving the patient something to hold, assisting the patient while doing it, and then asking the patient, we have to move this bottle from this place to the, let's say, point A to point B. I'm putting a colored marker on the table and asking the patient, you have to lift it and reach to this colored marker. Okay. or maybe reminding the patient of the task they have done earlier. That you have to, for example, if it's a lady, you're holding rolling pin in your hand, move it up and down. If there had been a person who is driving scooter, right, or motorcycle, and reminding them how do you really put gears, or how do you accelerate your bike or scooter. Same function of wrist extension, but now you've made it task specific. You've attached a meaning to it. The next principle of neuroplasticity, salience. So when you add meaning and you make it a task specific with a end goal to achieve kind of meaningful activity, brain adapts to that thing faster. Brain find ways to create those neural signals faster. And this is the cornerstone of a better recovery. A lot of researches, evidence-based practices have proven these principles to be true, and it's time we incorporate them in our clinical practice. Instead of going back to the traditional methods of doing the same exercises in a way, every repetition, every task should be designed keeping these principles in mind. So, intensity, repetition, specificity, and salience. That means meaningful activities which engage patients' motivation to bring faster neuroplastic changes. And when I talk about the time, I mean that time is a very important, sensitive window when the recovery happens. We all have heard that the initial 60 or 90 days post stroke are crucial. Why? Because brain is very, very particular to respond to whatever actions are happening, whatever efforts are being put during that time. It's not like in a chronic case, changes will not happen. Even in a 90-year-old patient, brain can adapt change, but the possibility or the time taken to bring that change will be lesser. It will be faster to get response and results if we start early. So time sensitivity is important. Imagine again the same scenario. The road is blocked. Somebody is trying to come and try to figure out a way how to go beyond this blockage. And imagine nobody came on that road for 6 months, 3 months, ever trying to figure out which way to go and how to go beyond that blockage to find something. What will happen? Grass will grow in the surrounding areas. There will be hardly any route available, possibly, and those possibilities will be lost. But if somebody is coming, what happens? One person goes slight change. Two people are going more changes, and multiple time if the repetitions are happening, there will be an actual pathway established, a collateral route established. So this is the power of neuroplasticity, and we will be today learning that these with these principles we can modify and modulate the hand rehabilitation or even the lower limb rehabilitation in a stroke patient, right? So now another let's move to the next concept of how positioning and handling techniques are important, right? Now see, what do we mean by positioning techniques? When the patient is lying in the bed, when the patient is sitting in chair or in the bed, how are they keeping their position? How are they positioning their affected side? Why are we focusing on it? To prevent secondary complications, to manage the existing issues, and to create an optimal environment for recovery. So I have covered it in 4 fragments. Lying on the affected side. If the patient is, let's say, sleeping on the affected side, so the arm should be forward, shoulder blade flat, arm slightly forward, and leg should be straight, and there should be a pillow under the upper arm. Wrist and finger should be extended. You can keep that hand in that way by using splints so that the wrist is and the fingers are not going into flexion and spasticity pattern. Even if the patient is in the flaccid stage, the first stage, ensuring that the range of motion is there properly and there's no swelling in the hand, keeping the fingers extended for the majority of the time allows us to keep the range of motion proper. Secondly, when the patient is lying on the unaffected side, so the affected side is above, what you have to do? Again, shoulder protracted, forward, elbow extended, wrist in neutral position, and affected arm supported in the front of the body for the visual feedback. So the patient is able to see his affected side, right? And not neglecting the affected side. If the patient is lying in the supine, keep a pillow under the affected blade. Again, to keep the scapula in protraction, avoiding the retraction. We want the scapula to be protracted properly and giving support on the pillow so that there is no swelling on the hand. Keep the hand little above the heart level. Wrist should be extended, fingers should be open. Closed fingers we do not want. Eventually that would lead to poor blood flow and swelling and stiffness in the fingers. So keeping the hand open is always a better idea. And when the patient is in sitting, keeping the affected arm supported on the table instead of the arm dropped and patient sitting randomly, always ensure there is either a tabletop kind of thing available for them. They are eating their food, they are, watching TV, sitting, keeping their hands on the tabletop. It's important. Or if they are not sitting in the bed, preferably sitting on a chair, again, there is some kind of support given to their, maybe over their arm chair rest, some board or some kind of modification done so that their hands are supported on the table. And if there is no table, we can use 2 to 3 pillows on their lap to support the hands. Elbows in flexion, wrist neutral, and fingers extended. So that is the functional position where it's easy for the patient to do various activities and prevent contractures and reduce edema, right? And if we're keeping the shoulder into protraction, it also minimizes the possibility of shoulder subluxation, which is again a very common problem post-stroke cases. So shoulder hand pain syndrome, if you all have heard of, it is common only in patients who have neglected the positioning technique. If positioning is taught properly in the initial stages as a home care regime, shoulder hand syndrome will not develop. Shoulder subluxation will not happen. And when the patient has a better proximal control, distal activities will be far more easier for us to achieve. If we talk about hand specifically, it's always better to maintain the wrist into slight extension, right? This position, what is the most functional position for the hand? Wrist in slight extension, fingers in slight neutral position, and thumb in the opposition. Thumb in the opposition, because this is how we can grasp objects. If they have to hold the pillow, if they have to hold the glass to drink water, hold the spoon, anything, the fingers should be slightly flexed and the wrist has to be in extension slightly. With the wrist in flexion, fingers in flexion, they cannot really achieve any functional task. So you can give a splint designed in this kind of positioning for the hand, right? And this position will also maintain the optimal muscle length, preparing the hand for functional use, right? Now, coming on to my favorite part, priming techniques, sensory priming techniques. As a physio, you're starting the rehab session for a patient. But before touching the motor component, understand sensory priming is a crucial thing which most physios at times miss out. What we do, let us start training the hand, let us start training the muscles. No, before that, we need to work on the sensory priming too. Because unless the patient's sensory priming is done, motor output cannot be 100%. We are always missing out on something which could have given better cortical excitability. Because if the signals from the periphery are going to the brain, only then the brain will be delivering better outputs, right? So the sensory corticospinal pathways, excitability of the cortical maps for the area hand sensory signals are representing will ensure that multiple routes are being tapped. Excitability of the brain is happening at multiple levels, not just only on the motor output, right? So it prepares the brain for more effective motor learning. And how can we achieve sensory priming? One, the traditional methods, by giving a cotton touch, by tapping the hand, using the ice hot, any kind of taking a cloth and rubbing the hand on that side, or by using peripheral nerve stimulation. Now electrical stimulation is also a kind of sensory priming, right? It serves dual purpose. It is giving sensory priming also, and it is also eliciting the response on the parietic muscle, right? Vibration therapy, mechanical oscillation to muscles and tendons, that will also enhance the proprioceptive and modulate. It helps in modulating the muscle tone of the affected side. Then another tool we can use? Mirror therapy. Mirror therapy works beautifully, acting as dual role. Acting as a sensory priming tool also, because visual feedback is happening, and it acts as a great neuroplasticity tool also because it activates the mirror neurons. So how do we do mirror therapy? Very simple. You create, I find it very easy. You take a folder, place a, these days you get sticker mirrors. Place a sticker mirror on one of the side, just like shown in this image here. Make sure the patient's affected hand is inside that folder box and the patient's non-affected side is outside. So the patient is able to see the image of the non-affected side in the mirror. Now this hand he is able to do pronation, supination, flexion, extension, all activities. And when the patient is looking in the mirror, it gives signals to his brain that his affected side is moving. It has three benefits. It activates the mirror neuron system, sending signals to the brain that my affected side is moving. It improves the motor planning. Brain starts sending signals to the affected side to execute that function the eyes are seeing right now. And it reduces the pain perception also, which is often a outcome we want to work on to improve the patient's participation in the therapy session. If patient is having pain, swelling, they're unlikely to listen to you and do the activities. But if you're working on their pain perception reduction, they're more likely to listen to you and cooperate with you too. You agree with me on that, right? So these are the tools and techniques. One more clinical tip I'll share with you here is, so ask the patient to use a hand towel, and whichever side is affected. If right is affected, they will hold the hand in the left side, vice versa, and ask them to rub the hand from fingertips to shoulder with the towel, right? Make them do this as a homework for at least 100 repetitions every day. And make sure they're doing it at different times of the day, like 30 repetitions at least 3 4 times in a day. This will prime their affected side. This will not let them go into the learned non-use kind of thing. They will be aware of the affected side. And it doesn't take any effort. They have to just position the affected side properly and use their non-affected side to do that task, right? Secondly, you can ask them to take their comb and again stroke the hand from fingertips to the shoulder. Different sensory input you're trying. Then you can ask them to take a form, a small form sponge, use it in the same way. Then you can ask them to take a silk cloth and do the same repetition on the dorsum side, ventral side. Preferably, if we are working on making the patient come out of synergy pattern, you can go the roots approach way and make the patient do these stroking activities on the extensor side so that we are eliciting the extensor response and inhibiting the flexor synergy pattern and making the patient's motor output easy, right? Creating time for that, creating space for that in a way, right? Then once we have done the sensory priming thing, moving towards the motor control and relearning approaches. Now, it's important to understand that motor learning is brain's ability. Brain has the capacity to relearn whatever task we have done earlier. Now we're just kind of retraining the brain to learn it again, right? And as we discussed earlier in the neuroplasticity principle, if we can make that task functional, if we can make that activity task oriented, right, we are going to get faster, better results. We just have to emphasize on making it meaningful, functional, right? And this approach is widely used throughout the world now. It is in contrast of that impairment oriented training, which used to focus on repeating the flexion, extension, and the basic things. Now we are focusing on the real world activities. So what we do now, everybody understands MRP was given by Karen Shefford, and he assumed that motor relearning requires repetitive task specific training to restore the motor control. And if we combine it with some electrical stimulation, it will improve the upper limb function, right? Now, what happens is when we are repeating the specific task, brain is reorganizing, cortex is relearning, and that lost function is being mapped again. Okay, now let's discuss what tasks can we do, what functional task practice can we give the patient to improve the hand function and activities of daily living. My favorite part is I ask the patient what you used to do beforehand. So all, and it will be different for every patient. It cannot be same for everyone. That's why talking to patient, taking their clinical history, understanding their problem is important, because you want to identify if patient was a teacher writing on the blackboard, if patient was an IT engineer typing the whole day or thinking and using the hand to use a computer, or if patient was a driver, or if patient was a musician playing piano. So what activity meant most to that person? Was it a housewife, doing some cooking meals or that kind of stuff? Once you identify and have a list of functional tasks relevant to the patient, meaningful to the patient, you can design your therapy according to that. You can incorporate and break down your therapy session into those activities, into those oriented activities. And when we teach a skill to the patient, we can then transfer it to their everyday context. Now, for example, I have to train the patient to drink water by themselves. His right side is affected, right? So what we can do, we can ask the patient to practice holding the bottle, initially the wider object, right? And then initially by assisting the patient to do that activity, and then later on asking the patient to transfer that learned skill into the actual activity every single time he's drinking water at home. That is most important thing, teaching it and transferring the skill back at home. So as a physio, our job doesn't finish right when we send them back to their home after teaching or taking the session. Making them understand the importance of practicing that skill back at the home also will significantly change how fast you can achieve that function in the patient. So patient has to transfer that skill into the everyday context. Similarly, if like what more activities can we give to the patient? We can ask the patient to hold a brush or hold a spoon, right? Now what it needs the pincer grasp, right? So we begin with the wider objects and then we move on to the smaller grasp or the smaller size objects, right? Activities can be different, but if the activity is meaningful to the patient as per what is missing in their daily routine at the moment, you will be right at that point where the patient is going to listen to you, because you're talking about what they want to achieve. Right now, I'll share a clinical experience I had once. I was working on a lady who was around 68-year-old, and she had difficulty in using the washroom every day. She was having difficulty in really holding the or grabbing that jet or the thing. But while we were working on her arm and other functions, when I discussed what exactly is the most challenging thing you're facing through the day, she shared with me that uh, you know I have difficulty in the grasp also and the strength also. So when I understood what function she's missing specifically, I broke it down, and tried making her do the step by step task outside in during the therapy session. And when we repeated it over a week to 10 days time, that function improved. So what we were doing, we were learning the same steps of maybe, grasping, and through various activities. You can give the patient a roll of socks to work on the grasp and the strength of the hand, and you can give them uh, something which is as wide as the object they are finding difficulty in holding in the real life during the therapy session to practice. And you're making them do step by step activity, they can learn that task and transfer it when they're actually doing that task, right? So understanding the patient's problem is crucial to achieve the recovery. That's the point I want to make here, right? Now, you must have heard about CIMT also. This is also one of the core neuroplasticity based approach which came earlier, that let us make the patient do it from the let's almost put a position to use the affected side by constraining the non-affected side. And a lot of evidence-based interventions, researches are done to prove it, that if we are doing the CIMT, constraint-induced movement therapy, it improves the patient's outcomes. So what is the core principle behind it? Restraining the unaffected limb to force use the paretic hand. And what are we achieving with it? Overcoming the learned non-use through constraint-induced movement. Now, this has worked wonders. Why? Because you're forcing the brain to go through that blocked route, forcing to find a way. We are not allowing you to use the normal side or the non-affected side. We are forcing you to find a way to tap into those neural pathways through that affected side only. Initially, it came as a frustration to the patient because the original CIMT said that 90% of waking hours should be spent in restraint. That meant more than 6 hours per day for one-to-one therapy, right? But later on, it was modified that let's make it up to 2-3 hours, give shorter sessions to the patient with lesser restraint, right? So even modified CIMT was very successful. And there are two factors on which evidence-based review have shown impact. Small effect on the arm function, but moderate effect on the dexterity. So the dexterity improves significantly, right? And whose is it most suitable for? For people who are totally neglecting the side. So people who are going into the learned non-use, you come across a lot of people who are going into the learned non-use when the hand is affected, trying CIMT in their home routine for 2 hours, 4 hours per day, by making them understand how it functions, how it works, will ensure their cooperation. And it will also be helpful for people who are having some residual motor function. Maybe it is not very successful approach for people who have zero function at that time, or those who are with a lot of pain and spasticity. But those who fit into this criteria of residual motor function and without any severe pain or spasticity, CIMT comes as a effective tool which we can utilize. So this is the image you can see. The patient is given straps, the affected side is kept open and the non-affected side is tied to the body. So the patient doesn't attempt or find an easy way to whatever things the person has to do during the day, through the day, with the non-affected side. It forces the patient to use or push through their paretic side. Functional electrical stimulation is also coming up as a very promising method in which we can improve and work in the stroke hand rehabilitation. How? It improves the motor function by re-educating the muscle, again through sensory feedback, through facilitating the voluntary movement, and improving the hand activities, right? Again, as I discussed earlier, if we are giving the functional electrical stimulation, it also prevents shoulder subluxation, because the muscles around the shoulder are the core in providing the proximal stability for the distal hand to really have proper function. So if the patient is showing any kind of disuser trophy, because of if the patient has not done any activity for long, doing FES on the shoulder can prevent shoulder subluxation also. It is actually used as a recommended tool in UK, national guidelines also. In cases, it if it is combined with the task specific training, it is shown to have improved functional outcomes also. Right? Now, I'll not go too much in details of it, how it works, but let's say if a patient is given FES in the subacute stage, then the patient has best results with this. And as physios, we should know that what are the techniques and tools available in current scenario. Now that we are living in a AI age, a lot of tools and techniques have come up where we can control it manually. We can control it through brain computer interface technologies, transcranial stimulation, non-invasive transcranial stimulation, EMG controlled FES stimulation, where the machines pick up the electrical signals from the patient's voluntary effort, modulate it, amplify it, and make it easy for the patient to do that function. In fact, a lot of assistive devices and orthotics are coming up. If you have heard about SIBO glove is again a dynamic orthosis which is used in the hand therapy and rehabilitation quite often. And how it works, it assists the finger extension and facilitates the grasping, because when the patient is in a stroke, subacute or a little chronic stage, the hand is fixed in this position. The major problem patient finds difficulty with is opening the hand or releasing the objects, right? So SIBO glove is designed in such a way that it helps in the finger extension. So release is easy because patient has some capacity to grasp objects, but releasing is difficult. So that's where it comes into the help. And it works in the format of spiral forearm design with some tensioners at the IP joint, right? And now what more is there? We have a lot of other activities, like there is Motus Hand, which is again a kind of exoskeleton based tool, robotic device. How it works, it makes the patient do a lot of repetitions, because again it's practically difficult at times to continue with the therapy session for multiple hours. At max we can take one patient for 1 hour, 1.5 hour, but patient needs a lot of repetitions. And let me share an interesting fact with you. In neuroplasticity, it is said that a patient, if does 300 to 400 repetitions of one task every day, that's the like minimum recommended dose for the effective function, functional recovery. But it's very difficult to achieve 300, 400 repetitions for every task. If we start doing so much repetitions in the therapy, it will be really difficult to end the therapy session in an hour's time. Not possible. So what happens is when these devices come, they act as a patient support system. They can do their homework, their home exercises with the help of these devices. They allow the patient to do high repetition task practice, which again enhances their finger strength training, which help in achieving the functional task faster. Now there's one more tool which is Neofect Extender, which works on mild hand spasticity cases. And again, it is also kind of exoskeleton, which is a wearable device acting with a software. It the patient wears it, it detects the signals from the hand, works on the software. The patient has to look into the application the patient is using in the phone or the computer, and it gives the feedback to the patient so they can try to achieve a task. In the screen it shows, okay, the feedback is there if the patient is able to achieve the task or not. So these technologies and tools are very effective in telerehabilitation cases, in remote therapies, and at times in faster recovery when patient cannot spend too many hours in the clinic on the recovery. So these tools are quite effective, and as physios we must be aware about them. Though clinically I don't see too many tools commonly, but yes, being aware about it, we can in future try to incorporate more and more in the clinical practices. And what do we do in normally? We have digital pegboards also. Now in a traditional practice, pegboards or keeping lot of hand table, where multiple tasks are set up is given, right? in today's session, will take few examples of common exercises that we can take with the patient in a clinical scenario. Like very common thing is, making the patient uh, open and close a water bottle, right? Giving that activity, holding a glass and placing it at different positions from point A to point B, right? Then as the patient improves, is able to take the resistance on the wrist, making the patient do wrist extension activities, giving either manual resistance or using a TheraBand to create that resistance exercise for the patient. While doing the exercises, always ensure you're giving some feedback for the patient to see as a okay, I've achieved this task or not. So when you give a endpoint to achieve, they are more goal oriented. Now, for example, if I have to encourage the wrist extension, I'll keep maybe an object and ask the patient to push that object, doing the effort. Even if I have to assist the patient in that task, or the patient is wearing a device and we're asking the patient to do that task, it's more likely if I'm keeping a place, an object for him to displace, right? This allows the patient to learn the task better. What more can we do? Functional task, as I talked about. So maybe giving them, asking them to bring their utensils or spoon, to hold and try achieving the same task of trying to, bring the spoon to mouth. Now, initially, it is difficult to achieve narrow grip. So what we can do, we can tie up the same utensil or object with some sort of cloth or some foam piece and make it wider, because wider grip will be easy for the patient to hold. But emphasis is on doing that same functional task, even if it is without any kind of it is not the ideal task, but we are adapting the device so that patient is feeling, okay, I'm using the spoon to achieve my task of eating food. So adapting it as per the different stages, and as the patient is moving towards the narrow grasp, reducing the foam over that spoon, reducing the assistance you are trying to give with the manual support of the therapist. This is how you progress with the patient. Same goes with the toothbrush. So you can scaffold the toothbrush and let the patient do the same activity, because the focus is on the functional task. Assistance is given, and as progression is happening, assistance is reducing. Also asking them to hold a comb their hair, right? Taking a t-shirt and making them pull it down, holding it down, buttoning the shirt, unbuttoning the shirt. So multiple functional tasks we can take. You can be as creative as possible, right, while listing down the task for the patient. In fact, I can share a list of multiple tasks at the end of the webinar with the participants to go through multiple activities that they can incorporate in their clinical session. But the idea is to think through, identify the challenges patient is facing, and design the exercise program according to that, right? One of my favorite activities also to help them open and lock the help them open a lock using a key, because the grasp we need for a key is a different grasp, right? The pincer grasp, and the grasp we need to hold a pen is different, right? So identify different activities and then merge them into the everyday task. Okay. Now what we can do is, we can, for example, make the patient hold a paper and tear it. For example, tearing the paper activity. This again acts as a uh, activity improving the grasp function and adding a little strength also. But when we are asking the patient to hold a key, the grasp is different. So if I have to work on that, what I'll initially give patient maybe a wider object, like for example, a phone or a notebook, right? And asking the patient to push and pull it. So you are working on the strength also, and you're asking the patient to hold it in this position. Now it's the same grasp as we do with the key, but the object is different. The width is different. So add a variety of tasks so that weight of the object is different. the texture is different, the context is different, and then transfer that skill in different contexts so the patient's brain is able to adapt to variety of tasks and carry this learning of through the neuroplasticity principle into multiple activities in their rehabilitation process, right? And again, making it more context specific, let's understand a bit through the stage specific exercise recovery. So, in the initial recovery, stage one, when there is flaccidity, what are we mainly focusing on? We are focusing on the passive range of motion and ensuring that range of motion we are not going excessive because a lot of sometimes without complete knowledge what I've seen initially students doing excessive range of motion that can lead to damage of the muscle. So make sure you're doing the full range of motion but not going excessively. Positioning is crucial in the flaccidity stage. Why? We discussed it. To maintain the joint integrity and avoid contractures. And then flaccidity actually is the right stage when the patient is maybe in ICU or in the recovery room or maybe have just got discharged from the hospital. There's not much to do, but what you can do, you can start with the sensory stimulation. You can start with the tactile stimulation with different kind of cloth texture, icing, and other activities to increase their sensory awareness. So there is no delaying in the recovery process. Start as early as possible. Even if it is day one, day two, there is something a physio can do. Working towards the stage two, when the spasticity appears, we have to continue with passive exercises. Now, the difference between a, a good physio and a very good physio would be the smart decision to identify how much of a movement should be passive and how to get the patient to start putting effort in that movement. So the active the transfer of passive to active assistive movement and from active assistive to active movement and from active to resisted movement, the shift has to come from your intelligence. Shift has to come from how you are checking the patient do those kind of encourage. How do you encourage the patient to really participate in your activity and not just kind of, okay, I'm doing the task and the patient is just not participating. That's where our role comes in. Of course, making it easy for the patient by inhibiting the spasticity through the weight bearing activities. One of the very, very successful approaches, making the patient push your hand, like they can push your hand with, you can stabilize the elbow with a splint and use it to push you so that even scapula on the shoulder is coming protraction and the patient is able to pass weight through all the joints, giving it as a inhibitory technique also, working on the co-contraction of muscles also, and makes patient aware about the affected side, paretic side also. Wonderful activity. It can be used to shift the body weight from one side to the another side. You can use them to push the wall if the patient is standing, or if nothing, just push your hand. As a therapist, you can feel how much of pressure patient is exerting, how much of control they have in the shoulder, elbow, and wrist joint. So try that activity in stage two. As the patient progress, moving towards active assisted exercises, less and less help to the patient, more and more focus on patient initiating the movement, right? And we are now timing the pattern. That means whenever the movement is coming, initially making the most of it. Like if we know the flexion at the elbow is coming, let's make the most of it. We know the patient is in that stage, giving them a little bit of activities where the patient is bringing spoon to the mouth or bringing the glass to the mouth. So you're timing that synergy pattern. And when that activity has come and the patient is like doing too much of elbow flexion, you feel then making the patient come out of the synergy pattern. So working towards elbow extension and wrist extension activities, right? That's important. And in the same stage, a very successful activity can be done is doing isometric co-contractions, isometric holds of shoulder flexion extension, abduction adduction, giving them opportunities, again making it task specific. How do I do it? A very simple clinical tip and example I'll give. I make maybe patient hold a pillow or a ball or let's say any object, and making the patient range from side A to side B, right? And then stopping in between in different angles at different positions, making the patient move forward and backward. So I'm trying to achieve isometric contractions in different ranges, right? When the shoulder is at a different flexion range, elbow is at a different flexion range, and at the same time, I'm keeping it functional as the patient is holding something in the hand. It is not like you move your hand and give me resistance. While we are doing some activity, I'm trying to achieve the concept of co-contraction or isometric movement with merging it with a functional task. Therapy ball squeezes, again, how you can do it, you can maybe have a toy which makes noise so the patient knows I'm squeezing enough to make a noise. Again, pouring something out of, like, if you can have something which comes out of it, or jelly kind of objects which make squishes which make a different shape when the patient is exerting a force. Therapy putty is a wonderful example, breaking the putty. So multiple activities can be used in this stage to enhance the motor output of the patient. As the spasticity decreases and more voluntary control starts to emerge, we work towards working the anti-gravity activities, like working on the wrist extension. Now, when you're working on the wrist extension, keeping the positioning of the hand is very important. For the wrist extension to come, when the shoulder is in flexion, elbow is in flexion as the patient is in sitting, and then you try getting the wrist extension in the anti-gravity in gravity eliminated position initially, it will be easy. And once that is achieved with the resistance, then you can try the anti-gravity position, right? Similarly, working on the, now at this stage we can work on the isolated movements also, working on the finger abduction, adduction. How? By giving them uh, you know uh, these kind of therapy band, right? Or giving them again activities that I'm placing two coins here, and you have to move these coins with your fingers. You have to stack the coins one on the another, right? So as the patient is progressing from stage 4 to 5 to 6, your activities will keep on changing and advancing. Complex movements start to be added in the routine, allowing for various combinations of variety of flexion extension at the IP joints, PIP and DIP joints, right? So turning the pages, tearing of the pages, or using both hands, bilateral hand coordination activities will ensure the patient is giving multiple opportunities to the brain to utilize the ipsilateral and contralateral hemispheres learning pathways to achieve functional tasks, right? And as the patient works towards near normal function, then adding the difficulty, segregating rajma from different kind of beans or different kind of small pulses, and picking it, weeding it out from one bowl where everything is mixed to separate bowls, or giving them coins of 1 rupee, 2 rupee, 5 rupee and asking them to segregate them, or giving them cards and asking them to flip them every time, from the stack. So making it difficult as the patient progress, working on the strength, dexterity, and variety of functional activities, right? So that's the whole idea, how we can incorporate and take the patient towards work related activities. The concept is to make the patient achieve the functional task the person was doing earlier, and not just clinically feel okay the patient is 5 on 5. That's going to happen, but it's going to be easy and better and faster if we are making it functional for the patient. So what I would like to say at the end, that if we are working on combination of strategies, combining the modalities, results will be faster and better. Like how? If we are combining the functional electrical stimulation with task oriented training, what will we achieve? We are working on the paretic muscles and we are facilitating the movement also. So what's happening? The patient is able to now initiate the wrist extension with the FES, and we are adding the functional task of holding a bottle and moving it from side point A to point B, right? So combining it will deliver better functions. because it gives a, purpose to the brain. It makes the brain more engaging in that purposeful movement, right? Similarly, for the robotic activities also, we can say the same thing. If we are making the patient do a constrained induced movement therapy, CIMT, then we are adding a robotic device and we are giving feedback to the patient. We are helping the patient do multiple repetitions through the day with the robot assisted activities. That is going to make the training session more productive, right? And it will create a powerful rehabilitation environment. Okay, so strategic combination of modalities addresses multiple aspects of recovery, and that's how we leverage different mechanisms to optimize neuroplasticity and functional outcomes. It's a small case study I've discussed. There was a patient, who again presented with a stroke, 58-year-old male with ischemia. It was a subacute case with around 4 months post-stroke, brainstorm stage 3 hand recovery, right side hemiparesis. The goal was to hold a cup and feed independently. I missed discussing assessment tools initially, so here I'll go through that. Common assessment tools for upper limb mostly are Fugl-Meyer assessment scale, of course, where we can take the upper limb component. We can also go for ART test, action research arm test, where we can work on 66 parameters are there. The scoring is 66, where grasp, release, grip, multiple things are checked. And then the treatment was planned in a way that first thing was sensory priming, starting with that, working on the vibration to wrist extensors, working on the sensory discrimination task, making the patient close eyes and identifying what kind of texture is there, what kind of touch is there, heavy weight, light weight, is this weight is heavier or the other weight is heavier. So giving a lot of sensory discrimination tasks to the patient. Then working on the positioning, making sure patient is aware of the paretic side, looking over the paretic side while talking to relatives, while attending to different activities, or during the day, sitting with the hand in a functional use position, using the resting hand splint. Adding functional electrical stimulation for at least 30 minutes every day, 5 days in a week. Main focus was on the wrist extension and finger extension because the goal was to hold the cup and release it. Okay. Then making the patient go through task specific exercises for 45 minutes. So a total rehab session looked like a 1.5 hour session for this patient. And then we focused on high repetition training and giving them a home exercise program for all kind of wrist extension activities we could think of. Pushing the pillow on the side, holding the hand, moving it laterally on the dining table, uh, throwing a paper across, again working on the wrist extension, imagining you're giving race to your scooter, adding multiple activities, aim single, achieving wrist extension. It led us to have better recovery within 6 to 8 weeks time. So coming towards the conclusion of the webinar, let us have some key takeaways from today's session. We have to work on the neuroplasticity based approach, which is evidence based and which is crucial in optimizing the recovery. We have to go through recovery stages, understanding the brainstorm stages, how from flaccid hand to functional hand we can add stage specific interventions, understanding the protective positioning, how it prevents complications, prevents contractures, and creates a positioning for optimal environment of the hand, giving optimal environment and positioning for the hand for recovery. Taking help of the advanced technologies, assistive devices, robotic interventions, again, working on the intensity and specificity of treatments. This gives us a lot of future directions that in future, rehabilitation will be tailored according to the individual patient's characteristics and their personal recovery patterns. Smart technologies and robotics will integrate, the rehab intensity and specificity. Telerehabilitation is a powerful tool which definitely is going to be the future because it will it will give access to even people sitting in remote areas. And when we collaborate and do combination activities among various healthcare professionals, we can address the stroke recovery needs more effectively. So the journey from flaccid to functional recovery requires evidence-based strategies, technological innovation, and collaborative care. So that's the session from my side today. I hope you have had some positive takeaways from the session. Now I hand over to Dr. Nishtha for question answers. You can drop your questions in the chat box also.
So thank you, ma'am, for the innovative session. Is there any query from any side?
Ma'am, in the chat box we have the questions. So would you like to ask that, Nishta ma'am?
So there is no question in my chat box.
Okay. I'll be checking it out. Ma'am, there is a question. Like, how many repetitions do you suggest at one time? Like in one session for one moment, how much repetition to be given?
Am I audible?
Yes, ma'am, you are audible.
Okay, so see, as I said, if I talk about the research papers, the ideal recommendation is 300 to 400 repetitions, right? For the plasticity to be successful, but that's difficult to achieve. So I keep a standard of 30 repetitions, 3 sets. So at least we are close to 90 to 100 repetitions for one task. And at times you have to be little smart. Like, for example, I'm working on the wrist extension function. So rather than giving 10 activities, I will maybe focus on 2 activities in one therapy session, and will focus on those functional tasks only. So my 200 repetitions of wrist extension are achieved, my functional task is achieved, and then I'll maybe, for example, I wanted the patient to do more activities. I create it as a homework for the patient and ask them to do it. For every stroke patient, as a rule, I ask them to create a diary where I give them task, and I design a home program and ask them to really repeat it and check it the next day. It includes their sensory priming, like you have to rub your cloth on the arm from hand, shoulder to the fingers so many times, asking them to move the pillow from one place to the another so many times. So, whatever you feel the patient needs maximum assistance, make them do that activity in the clinic in front of you, working on the right open feedback system and loop. And rest of the things you can make them practice at home. But at least, let's say, for one functional outcome for wrist extension, my aim would be to achieve 300 plus repetitions through the day, some in the clinic, some back at the home. I hope that answers the query.
Yes, ma'am. And second question is, at what area we have to work first to activate shoulder muscle or hand function?
Absolutely, you have to work on the proximal stability first, because unless proximal stability is there, you cannot really achieve the distal hand function. So I always start with sensory priming and then working on the shoulder first, working on the protraction, retraction functions, working on a bit of lifting the arm, working a little bit on the elbow, and then coming to the wrist and the fingers. So proximal to distal is the way, but then you also have to see and assess the patient. Where are they standing? What is their uh, assessment level at that point? So it's not always right to say that you have to go from shoulder to finger. Sometimes it's a mixed approach, and we have to try and achieve whatever function patient is showing us. But while taking my session, I prefer, that we should go from proximal to distal. That's the right way.
Okay, ma'am. And another question will be,
Yes, please.
uh, at what area, chances of recovery if patient have shoulder subluxation? The question is like that. The chances of recovery if patient have shoulder subluxation.
So, shoulder subluxation think it objectively. There are two, three problems. If the patient is having shoulder subluxation, we cannot really achieve the proximal stability, right? Two, patient will be in pain. So, the compliance will be poor. Patient is not going to listen to you do these hand activities. He will say, fix my shoulder first, right? So as a physio, what you can do is try taping, very effective and doable tip, right? Work on the positioning, give a splint to the patient to wear so that at least his shoulder is worked, and then start working on the distal part. So in this case, taking care of the problem area, fixing that issue, but at the same time, while the patient is working on stability of these muscles, which might take time of couple of weeks, work on the distal aspect, because you can't disturb the subluxed muscle at that moment much, because they of course all need time to really heal. You can't give too much movement there, but working on the distal aspect and the elbow will help the patient gain the confidence that my recovery is happening, and in the meantime patient recovers at the shoulder also, allowing you to take the entire course of rehab of the upper limb ahead.
Okay, ma'am. Uh, One more question. There are many questions, ma'am. So I'll be
Please,
taking
please
till
go
the
ahead. I think
220.
we can take whatever time allows us. Rest we can, I can answer. Everybody has my phone number. I think I'll just drop in the chat
Yeah,
box.
we have a few questions. I'll be asking few.
Yeah.
So the next question will be: is there any chance of recovery of hand after 1 or 2 years of stroke? How much time can their hand activity take?
Okay, I think that's interesting question. I was waiting such question to come up. Neuroplasticity says there is no denial in recovery, be it 5-year-old, 10-year-old patient. And in my own clinical practice, I have seen chronic cases quite often. So recovery will come, but time will be longer. The same recovery, which maybe you were able to achieve in 3 months' time, if a patient comes 3-4 months post stroke, versus if a patient is coming 1 to 2 year post stroke, the recovery will take maybe 1 year's time. So that it becomes slow, but if your repetition and consistency is there, you will achieve a function. I'll give an example. There was one case where the lady was working and she had made peace with, okay, my left hand is not functioning, it's fine, and she was moving on with her life, doing the job and all. And after she came about me, she visited us. So I asked her, what is the one thing that is troubling you the most and you want your left hand to do? She said, I find it difficult in locking the door, main door, because for that of course you need to pull the door and manipulate the knob and then use the right hand to lock the door. So I said, okay, let's work on that. So we've started working on that particular function of achieving the wrist flexion, extension, pronation, supination, and the grasp, the strength of the hand. And within I think 6 to 8 weeks, she said that I was able to actually lock the door independently. So recovery might come, it will come for sure, it will come, but time taken to achieve that functional task might be longer. Recovery never stops. Neuroplasticity says brain is pliable. It's ready to change anytime.
Okay, ma'am. There is another question. Can you please tell some techniques to activate shoulder muscle?
Okay, so shoulder muscle activation, again, first work on the sensory priming, because you have to give open up the map of the brain from where the signals are coming. Like you have to tap on that area, shoulder flexors, extensors, by giving vibration. A roots approach you can use the icing, stroking, tapping, and give the electrical stimulation also. After that, make the patient use a mental imagery of the patient. If nothing is there, let's say we are starting from stage 0 and you say the patient is not having anything, that's the work approach. Sensory priming, mental imagery, you help the patient do the movement, but ask the patient to contribute to it. And when you do it as a skilled physio, you will feel it in your hand when the patient is giving 10%, 5%, 1% effort to you. You will feel that while doing that activity or that movement with the patient. So that's your signal to know, okay, I have received 5% effort from the patient, 95% was mine, 5% was patient's. I can make it 10% in the next session, 15 in the next session. So that's how you find a roadmap in such cases. Ultimately, working on doing the active assisted activities only, but working on repeating the patient with your commands, that you have to lift it, you have to move it, and asking the patient to imagine he himself is doing it. Mirror therapy is again a wonderful tool, showing them from the non-affected side they're able to do it. That allows their brain to adapt and figure out a way to start working from the affected side. So yes, that's how we start with the recovery process.
Yes, ma'am. Ma'am, there is a question like, what if left humeral fracture? He unable to move hand while performing exercise in previous history.
So we have to wait for the humeral fracture to unite, of course. That's a co-existing condition. But again, in if the humeral fracture is there, you can definitely work on the wrist and the finger extension part. That's absolutely doable. So try and figure out in your assessment what is doable for me, what is achievable for me, what are the goals, what patient can do, list it, and what can't do. In can't do, what can be achievable, so try working on that, give the patient the recovery time, and then return to the shoulder and the elbow joints to achieve those functions, which once the bone unites and heals, we can definitely go ahead. The humerus fracture
Ma'am,
is not limiting.
yeah, yeah. I'll be taking a last one question, ma'am. In stroke hand rehabilitation, when training active movements affected by passive insufficiency, should we facilitate wrist extensor first or finger extensor first? Because when we extend the wrist, the fingers automatically flex due to the tendo disease effect or passive insufficiency. So, clinically,
Absolutely.
what should we begin with and why?
Absolutely. So this is a very intelligent question, and I think because it's a webinar of a short duration. Normally, I take these questions in the long workshops where we work on the activities. But I'll address this. See, what we have to do. This is why very normal. When you're working on the wrist extension, the fingers are going to come in the flexion, right? It's difficult for fingers to be extended. It needs a lot of voluntary control to achieve it. So the first goal for me is to work on the wrist extension, right? Once wrist extension starts to gain control, then I'm trying to gain some strength on my finger flexors. And activities for that would be keeping the wrist in 30-degree extension and try to achieve some, like, allowing the fingers to press down, dig down on the object. It could be I give putty or some jelly and ask the patient to press down the fingers while maintaining the wrist in extensions. So I'm combining two activities. I want the wrist to be in extension, fingers to be in flexion, and patient to hold that movement. Do it as a task, not missing out. So it is coming out of the synergy pattern, working towards a functional position of the hand, and once the control is better in it, then you work on the release part, maintaining the wrist in extension. Now I'm not working on the wrist further extension, at that same activity the wrist is maintained in extension, and I'm only asking the patient to release the fingers. So when the patient is releasing the pressure, technically it's finger extension which is happening, and then working on the range of motion for that, like maybe giving some cloth on, putting a little cloth on the fingers where he can see the fingers, but ask them to lift, unveil this, push this cloth out of your fingers, so that the finger extension is coming and helping us to release the objects. This is a very important function to achieve, because grasping comes easy for a patient. Wrist extension will be there, but releasing the object is again the one of the most challenging thing to achieve in hand rehabilitation. So we have to start working on the finger extension after achieving the wrist extension initially. I
Ma'am,
hope I have tried to cover it a little bit.
yes, ma'am. Ma'am, there is a request. Can you please elaborate on the assessment part?
Okay, so assessment, I would give you some tools to read as a homework, everybody, because this workshop was majorly on the rehabilitation part. For assessment, Fugel-Meyer assessment scale is a wonderful scale. Go with that. Usme pura, different parts are there for the upper limb assessment. AR 80 action research arm test is a great tool. Then in clinic na simple thing, box and block test or maybe 9 peg hole test. If nothing, we normally assess the patient's grasp by graspometer, right? So these are the common tools through which we understand, like if the patient is able to hold an object or not. Give them 4 5 objects to hold. How are they able to hold a wider object, maybe a pillow, or let's say a big ball, and then how they're able to do the smaller grasp. Are they able to hold a coin or a smaller object or maybe a piece of paper, right? So giving them different things, or in the 9 peg hole test is also one of the tools a lot of people use. You give them some blocks, set a timer, ask them to put the pegs into 9 holes and see how much minutes they took, and then you can redo the same test after a week. Idea is whatever test you choose, you can stick to 1 or 2 tests and stick on the same test again for the reassessment part, so that you have a clarity, are you moving forward or not, right? Rather than confusing yourself in too many assessment tests, as a clinician, keep one test. It could be 9 peg hole test, ART or Fugel test, and redo same test weekly, so you can find out where are we heading. Even patient knows, okay, I was not able to do it earlier, or I used to take maybe 30 seconds to do this peg hole test, and now I'm taking only 20 seconds. So it acts as a tool to measure your progress. That's why assessment is for.
Yes, ma'am. Over to Nishta, ma'am.
So, as we come to the end of today's enlightening webinar, I would like to take a moment to express my heartfelt gratitude to our speaker, Dr. Anu, for sharing her valuable insights and expertise. For your contribution has truly enriched our understanding for, of the topic. Thank you, ma'am, for such an enlightening session. We are truly inspired by your vast knowledge and practical experience. We look forward for many more such insightful and knowledgeable sharing webinar in future. A special thanks to all the participants for your active engagement, thoughtful questions, and the enthusiasm throughout the session. I hope all the participants gain valuable knowledge today and will apply it in their daily lives. I also extend my appreciation to the organizing team for their dedicated efforts behind the scene to make this webinar a success. Thank you so much, ma'am.
Thank you, Dr. Nishtha. Thank you, IAP, for creating and organizing this. And anybody having any questions and doubts, they can drop their queries in the webinar group we have made. I'll try to address them. Thank you, everyone. Shall we wind it?